Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. In today's podcast, we will delve into 8 compelling research studies. First up is an experimental study investigating Francine Shapiro's claim that EMDR therapy is a time-free therapy with similar effects on recent and old memories. Then we will explore whether group hatha yoga can serve as an effective pre-treatment stabilization intervention before starting trauma-focused EMDR therapy. Next, we will review results of a randomized clinical outcome study of early postpartum EMDR therapy for women with traumatic birth experiences. Then, another randomized controlled trial of dysmenorrhea, that is menstrual pain, that was carried out in Iran. Next, we cover a pioneering study from the UK of EMDR therapy for a range of functional neurological disorders. Then we will explore the highlights from the first fMRI study of EMDR therapy using the butterfly hug for women with cancer. Then we will broaden our scope with a systemic review of treatments for PTSD induced by a wide range of medical events. We will wrap up today's podcast with evidence from the Netherlands that many individuals who have been discharged from an intensive treatment program no longer meeting full diagnostic criteria for PTSD, nevertheless may continue to experience specific PTSD symptoms at their comprehensive 6-month follow-up. For those who want to access any of the original research papers mentioned in the podcast, you will find full references and links to each of these studies in the September 2025 blog on sonomapti.com. Just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the September 2025 listing. Okay, let's get started. Francine Shapiro always described EMDR therapy as a time-free form of psychotherapy. In her reference textbook, she wrote, "In the EAP model, the healing of psychological dysfunction is viewed as being comparatively time-free because rapid treatment effects can be observed when EMDR processing is initiated, regardless of the number of disturbing events and no matter how long ago they occurred." Now, this time-free claim has received research support in a 2025 experimental study from Kevin Van Schie of the Department of Medical and Clinical Psychology at Tilburg University in the Netherlands. He recruited 195 participants to investigate whether eye movements have equivalent effects on both old and new memories. Participants were asked to recall either an old or a new negative autobiographical memory and were randomly assigned to a recall plus dual task intervention or a recall-only intervention. Each memory was rated on vividness and unpleasantness before, during, and after the intervention. Now, the dual task used in the study was a letter identification task, in which a letter appeared repeatedly, alternating between the left and right side of the computer screen. Most of the alternating letters were presented in a relatively small font size, which were impossible for participants to read using peripheral vision and thus required them to focus their eyes on the letters. Participants were asked to watch for a larger target letter to appear and then to press the spacebar as quickly as possible. Target letters appeared twice during each 24-second interval. Participants were instructed to keep their heads still to induce horizontal eye movements. The results showed that the age of the memory did not change the effectiveness of a dual task intervention and supported the widespread clinical observations that dual task interventions, as used in EMDR therapy, are similarly effective for reducing the intensity of emotional memories of different ages. In a 2014 randomized controlled study, Bessel van der Kolk and co-authors reported that Hatha Yoga significantly reduced PTSD symptomology. The authors explained that yoga may improve the functioning of traumatized individuals by helping them to tolerate physical and sensory experiences associated with fear and helplessness, and to increase emotional awareness and affect tolerance. Now, in a recently published pilot study, Camille Aline, with a large group of French researchers, explored whether Hatha Yoga might serve as an effective pretreatment stabilization intervention before trauma-focused EMDR therapy. Patients selected for this research had childhood abuse-related post-traumatic stress disorder and experienced strong avoidance strategies toward their traumatic past. 32 adult women were randomly assigned to either a yoga plus EMDR group or a weight plus EMDR group. Those in the yoga plus EMDR group attended 10 weekly group yoga sessions, followed by 10 weekly EMDR sessions. Those in the weight plus EMDR group waited for 12 weeks, followed by 10 weekly EMDR therapy sessions. Assessments were conducted at baseline, week 12, and week 24 with multiple instruments. These included the CAPS-5, the PCL-5, the International Trauma Questionnaire, the Beck Depression Inventory, the Multidimensional Assessment of Interoceptive Awareness, the Dissociative Experiences Scale, the State Trait Anxiety Inventory, the Difficulties in Emotional Regulation Scale, and the Childhood Traumatic Experiences Questionnaire. These assessments revealed that PTSD symptoms and most comorbidities showed no significant group differences after 10 weeks of EMDR therapy. However, the Yoga plus EMDR group exhibited significantly larger reductions in anxiety and emotional dysregulation. Also, the Yoga plus EMDR group had fewer dropouts. All 12 Yoga plus EMDR participants completed their EMDR sessions, while only 7 out of 11 weight plus EMDR participants did so. The Yoga plus EMDR group members were also able to start EMDR reprocessing sooner in their 12-weekly EMDR sessions compared to the weight plus EMDR group. Thus, they were able to complete more reprocessing sessions. These results strengthen the value of a phase-based treatment for complex PTSD as recommended by several international treatment guidelines. The major limitation in this study is the small sample size. The authors explain this was due to the particularly long duration of actual treatment sessions, which extended well beyond the designated 6 months of the research protocol. Next, we turn to a 2025 randomized clinical outcome study of early postpartum EMDR therapy for women with traumatic birth experiences from Yvette Hendricks et al., published in the American Journal of Obstetrics and Gynecology. In their article, the authors point out that between 10 and 20% of women perceive childbirth as a traumatic experience, and this occurs in both medically complicated and in uncomplicated deliveries. PTSD develops in up to 20% of women after a perceived traumatic birth experience, and even more women exhibit subthreshold PTSD symptoms. This first-of-its-kind study investigated the effectiveness and safety of early trauma-focused EMDR therapy in reducing symptoms and incidence of PTSD at 9 weeks postpartum in women with traumatic birth experiences, compared with those in a control group who received care as usual. Over 10,000 women were screened from a hospital and 25 midwifery practices in Amsterdam. 861 reported a traumatic birth experience. These women were screened for rule-out factors, including those under 18, those who had a previous traumatic birth experience, a recent diagnosis of a psychiatric disorder, a recent suicide attempt, as well as those who experienced a stillbirth or intrauterine fetal deaths. 151 women were selected for the study. 76 were randomly assigned to the treatment group and 75 to the control group. After a few women withdrew consent, the final group sizes were 74 in the EMDR group and 69 in the control group. Those in the EMDR therapy group received 2 60-minute EMDR therapy sessions. Those in the control group received 2 telephone calls between 2 and 5 weeks postpartum. The primary outcome measure was symptoms of PTSD at 9 weeks postpartum, as assessed by the self-report PTSD checklist for DSM-5 and a structured interview with the CAPS-5. Secondary outcomes included symptoms of depression, mother-infant bonding, fear of childbirth, quality of life, and breastfeeding rates. The EMDR group showed a significantly larger reduction in PCL-5 scores compared to controls. Results from the CAPS-5 showed that 125 out of 138 participants, or just over 90%, fulfilled the criterion A for PTSD. PTSD symptom severity was significantly lower at 9 weeks postpartum in the EMDR group compared to those in the control group. Those in the EMDR group also showed a statistically significantly larger reduction in reported depressive symptoms. Although EMDR therapy improved mother-infant bonding scores, it did not reduce the incidence of bonding disorder, which was low in both groups. Importantly, no adverse events were observed in either group during the study. Limitations of this study were the short 9-week follow-up period and the lack of long-term follow-up measures. Without a second active treatment, participants were not blind to being in the active treatment group, which conceivably could have led to an overestimation of treatment effects. The authors comment that given the high prevalence of traumatic birth experiences, proactive assessment of birth experiences by healthcare providers is important. When birth is experienced as traumatic, standardized questionnaires such as the PCL-5 could help identify women at risk for persistent traumatic stress symptoms. Integrating mental health referral pathways into routine postpartum care would therefore enhance patient-centered support and improve maternal mental health outcomes. Staying with the theme of women's health issues, we turn next to a study of dysmenorrhea, that is, menstrual pain, that was carried out in Iran. This randomized controlled trial included 88 female university students who were randomly divided into 2 groups. Those in the active group received EMDR therapy for 1, 2, or 3 60-minute sessions, and those in the control group received no intervention. After completion of the study, those in the control group were offered EMDR therapy if they were interested. Inclusion criteria were dysmenorrhea scores greater than 4 on the 10-point visual analog scale. Exclusion factors were a history of mental illness, abdominal or pelvic surgery, seizures, vision problems, and cardiorespiratory disease. The 19-item short form of the MOOS Menstrual Distress Questionnaire was used to assess the physical and psychological symptoms that an individual experiences during menstruation. The main outcome assessed was intensity of dysmenorrhea. Other outcomes were menstrual pain duration, menstrual distress, and the need to take analgesics. Anxiety was also assessed using the Spielberger State Trait Anxiety Inventory. Assessments were conducted at 3 time points: before intervention and at 1 and 2 months after the EMDR sessions. All 8 phases of the EMDR therapy were performed in one treatment session, which lasted approximately 1 hour. Treatment sessions continued until each woman reached a SUD of 0 and a validity of cognition of 7. For those who needed it, a second session was held within 1 week. 3 of the participants received a third EMDR reprocessing session. 88 individuals with primary dysmenorrhea were assigned randomly into the 2 study groups. 5 women dropped out of each group. Study results showed that brief EMDR therapy significantly reduced dysmenorrhea intensity compared to controls at both follow-ups. In the EMDR group, pain duration also decreased significantly at the second 2-month follow-up. The need to take analgesics was also reduced for participants in the EMDR group compared to the control group. EMDR did not significantly reduce trait anxiety or non-menstrual phase distress. These findings suggest that EMDR therapy is effective in alleviating key dysmenorrhea symptoms, particularly pain intensity, menstrual phase-specific distress, and the need to take analgesics. Study limitations include the absence of study participants, a medical examination to exclude potential undiagnosed underlying medical conditions. The only measures were subjective self-report. Other factors that may influence dysmenorrhea, such as body mass index, level of physical activity, and nutritional factors, were not measured. The short follow-up period, only 2 months post-intervention, means the long-term stability of EMDR therapy's effects were not assessed. Most importantly, the absence of an active control condition makes it impossible to determine whether the observed improvements in dysmenorrhea intensity, menstrual distress, and analgesic use were due to EMDR therapy or non-specific factors such as participant expectations, therapist attention, or the therapeutic ritual. Despite these significant limitations, this preliminary present study suggests that a brief intervention with EMDR therapy might lead to a reduction in the intensity of menstrual pain and distress, as well as a reduction in the need for analgesic medication. A follow-up study with a second intervention group and longer-term follow-up research on this novel application of EMDR therapy seems warranted. Next, we turn to a pioneering study from the UK with lead author Sarah Cope, evaluating EMDR therapy for functional neurological disorders. Functional neurological disorders occur at the interface between neurology, psychiatry, and psychology. They are characterized by genuine motor, sensory, and perceptual changes that can cause significant distress and impairments. This includes motor issues, such as jerking of limbs and tremor, seizure-like episodes, cognitive issues such as brain fog, and sensory symptoms such as numbness or tingling, dizziness, and swallowing difficulties. 2 prior series of case reports with Sarah Cope as first author in 2018 and 2020 provided suggestive evidence of effectiveness in treating medically unexplained symptoms and functional neurological disorders. This 2025 report is the first controlled study of treating functional neurological disorders with EMDR therapy. This was a randomized controlled trial with two arms, EMDR plus standard neuropsychiatric care or standard neuropsychiatric care only. The two groups were compared at baseline, 3 months, 6 months, and 9 months. The study recruited 50 adult patients with a diagnosis of functional neurological disorder from a single neuropsychiatry service in the United Kingdom. Most were white women who were single, separated, or widowed. There were a similar number of participants with and without PTSD symptoms in each arm of the study. To be included, participants had to report at least one traumatic event from the International Trauma Exposure Measure. There were a large number of exclusion criteria. These included non-English speaking, major current stressors, such as domestic violence, homelessness, and unresolved legal issues, diagnosis of borderline personality disorder, or of chronic pain conditions, such as fibromyalgia or chronic fatigue syndrome, or a psychotic disorder, or dissociative identity disorder, uncontrolled epileptic seizures, an eating disorder, current severe self-harm, or strong suicidal ideation that required mental health services, current severe alcohol or drug use or dependence, current diazepam use of more than 10 milligrams per day, or receiving individual psychological therapy focused on functional neurological disorder. EMDR sessions were provided by fully trained but not yet accredited EMDR practitioners. Randomly selected recordings of reprocessing sessions were rated for fidelity by independent EMDR consultants using the EMDR Fidelity Rating Scale and were found to meet satisfactory protocol adherence with an average rating of 2 or more in the range between 0 and 3. Functional neurological disorder symptoms were assessed with the Ecological Momentary Assessment using the Empath app. Participants chose 1 or 2 symptoms at the beginning of the trial period to rate. They rated their chosen symptoms daily for 2 weeks at baseline and 3 months, 6 months, and 9 months follow-up. They answered 5 questions each day in reference to their chosen symptoms: frequency, severity, interference, distress, and preoccupation. In the EMDR plus standard care condition, 20 participants, or 40%, met PTSD diagnostic criteria, and in the standard care group, only 11 participants, or 44%, met PTSD criteria. Most of these were cases of childhood onset or complex PTSD. The mean number of EMDR therapy sessions completed in the intervention arm of the study was 13. All but 2 participants completed a minimum of 8 reprocessing sessions. 3/4 of the EMDR participants had their sessions online. A small number had a mixture of online and in-person sessions. For almost 80%, tapping was the form of bilateral stimulation used. In terms of adverse events, 13 participants in the EMDR plus standard care condition and 6 participants in the standard care condition reported 1 or more minor adverse events or reactions over the course of the study. In the EMDR plus standard care arm, no participant reported any serious adverse event. In the standard care only trial arm, 4 participants reported a serious adverse event which required hospitalization and/or surgery. An overwhelming majority of participants in the EMDR plus standard care condition perceived at least some degree of improvement in their functional neurological symptoms, and only 1 participant reported that one of their symptoms was minimally worse. In the EMDR group, a good improvement was reported by over 77% for their primary symptoms and by 57% for their secondary symptom. This compared to about 19% and 7% of those in the standard care only group. This study demonstrated feasibility in terms of recruitment, retention, and treatment adherence. The authors concluded that The results showed that EMDR can be delivered safely to people with functional neurological disorders by qualified practitioners who are receiving EMDR clinical supervision as long as adequate screening for suitability for EMDR therapy takes place. Note that in this study, they excluded any potential participant who was actively suicidal, psychotic, currently alcohol or illegal substance dependent, or with an eating disorder. They also excluded any potential participants with a diagnosis of dissociative identity disorder and screened for clinical levels of identity dissociation using the multi-scale dissociation inventory. One limitation of the study were factors that could not be controlled for, such as the number of neuropsychiatrist appointments in the trial period, or whether participants attended the educational groups offered by the service. It was also not possible for participants to be blind to treatment allocation, and the nature of the trial arms meant that participants had more clinician contact overall in the EMDR plus standard care arm compared to the standard care only group. In summary, this randomized study demonstrated feasibility and acceptability, as well as promising results in terms of functional neurological disorder symptom improvement, better mental health, reduced disability, and reduced healthcare costs for those who attended EMDR therapy based on a functional neurological disorder specific protocol for EMDR therapy. A full-scale trial with a second active alternative treatment is required to establish efficacy of EMDR therapy for functional neurological disorders. The vast majority of treatment outcome research and experimental studies on EMDR therapy has focused on the use of bilateral eye movements. Yet in the previous treatment study on functional neurological disorders, for 80% of the participants, tapping was the form of bilateral stimulation used, which resulted in good treatment effects in the majority of cases. So the question arises, what do we know about the use of tapping in EMDR therapy? Since the onset of the COVID-19 pandemic, remote delivery of EMDR therapy has become far more common. Remote EMDR therapy has used both bilateral eye movements, whether delivered by the clinician waving their hand in front of their camera, or with a moving ball on the computer screen. And other studies have used self-administered, alternating kinesthetic stimulation with the butterfly hug. The butterfly hug was developed by Lucy Artigas in her fieldwork with the survivors of Hurricane Pauline in Acapulco, Mexico in 1998. As the authors of our next remarkable research report inform us, there are now over 80 peer-reviewed published studies that have shown the effectiveness of various EMDR therapy interventions using the butterfly hug as a self-administered form of bilateral stimulation. This fascinating new neurological study from corresponding author Benito Estrada Arandalso reveals specific regions of the brain in which the butterfly hug exerts signature beneficial effects while using EMDR therapy for women with cancer. This study was carried out from 2017 to 2021 and appeared in the journal Revista Mexicana de Neurociencia in 2025. 20 women completed the intake interview and met the inclusion criteria. These criteria were being an adult woman, diagnosis of and treatment for cancer, having a PTSD diagnosis related to the cancer diagnosis and treatment, and being free of acute infection. The PTSD diagnosis of all participants was confirmed with a global assessment of post-traumatic stress disorder scale. Patient ages ranged from 41 to 68 years old. 15 had diagnoses of breast cancer, 2 had colon cancer, 2 had lung cancer, and 1 had lymphoma. Exclusion criteria were being in a terminal phase of cancer, ongoing self-harm or suicidal ideation, diagnosis of a psychotic, bipolar, or dissociative disorder, active chemical dependency, significant cognitive impairment, current trauma therapy, or medication for the management of PTSD symptoms. Participants were randomly assigned to one of 4 EMDR therapists trained in the EMDR-trained. The EMDR-trained is an individual EMDR therapy protocol that uses the standard 8-phase and 3-pronged approach of EMDR therapy. It was developed to address prolonged adverse experiences such as the ongoing stress of patients with a cancer-related PTSD diagnosis. The EMDR-trained protocol generally uses eye movements as the first choice method of bilateral stimulation. But this study involved administering bilateral stimulation while patients were inside an fMRI machine, which made administering bilateral eye movements impossible. Therefore, the authors decided to use the butterfly method for self-administered bilateral stimulation. The first session of the EMDR-trained was conducted in the therapist's private office, where the patient identified the targets for reprocessing by running a mental movie of their whole cancer-related experience up to the present moment and looking into the future. Then, the patient was scheduled for the first reprocessing session at the Radiology and Imaging Department of Ignacio Morones Prieto Central Hospital in San Luis Potosí, where the patient's brain activity was recorded using fMRI equipment. The worst part of the selected memory was reprocessed during this fMRI session using the EMDR-trained reprocessing phases with a butterfly hug for self-administered bilateral stimulation. The average time inside the fMRI machine was 55 minutes. When the fMRI study concluded, the therapist scheduled a follow-up appointment to continue the EMDR-trained to address any other disturbing parts, which were subsequently reprocessed in the therapist's private office. Here, let me mention limitations in the study included the relatively small sample size with only 20 subjects, the absence of a control group, and the lack of a randomized control trial design. The fMRI findings were averaged across the 20 participants in the study. There were several notable findings which I can only summarize here briefly. The open access article includes numerous graphs and images that report their findings in detail. Prior research had shown that the amygdala tends to show hyperactivation in individuals with PTSD, which is revealed in the fMRI by increased oxygen consumption. In this study as well, during remembering the worst part of the memory and before reprocessing, the study subjects showed hyperactivation in the amygdala, hippocampus, insula, and thalamus, and hypoactivation in the medial prefrontal cortex. Notably, the study found evidence of simultaneous changes across multiple brain regions during the reprocessing phases of the EMDR-trained using the butterfly hug, showing impacts on a broad range of brain circuits. After successful reprocessing, the findings from this fMRI study indicated a reduction in blood oxygen consumption in the limbic structures of the amygdala, hippocampus, insula, and thalamus, and an increase in blood oxygenation in the medial prefrontal cortex. This suggests a neuromodulator effect, normalizing brain function and leading to emotional stabilization. Despite its limitations, this study is notable for bringing us the first neurobiological data showing that successful EMDR processing using the EMDR-trained protocol administered with the butterfly hug is able to produce signature improvements in crucial brain areas that have been consistently found to be affected by those with PTSD. These are the specific and beneficial changes associated with recovery from PTSD. Next, we expand our view from the specific effects of cancer diagnosis and treatment to consider PTSD induced by a wider range of medical events. This is covered in a systematic review from corresponding and lead author Corinne Meinhausen from the University of California, Los Angeles, published in July 2025 in Health Psychology Review. The authors of this review point out that research on medically induced PTSD and its treatment has more than doubled in recent years. This includes those diagnosed with cardiovascular disease, cancer, HIV, and multiple sclerosis. Several interventions examined in this review have shown preliminary efficacy in reducing PTSD symptoms due to a range of medical traumas, led by studies involving EMDR therapy and other trauma-focused exposure interventions, emerging as particularly well supported when compared to various conditions across multiple studies. Altogether, the methods reviewed included 4 EMDR therapy studies, 2 trauma-focused CBT studies, 1 prolonged exposure study, and 1 written exposure therapy study. A few remaining studies examined included a non-trauma-focused CBT study, repetitive transcranial magnetic stimulation, and supportive therapy. These methods were found to have shown preliminary efficacy in the treatment of medically induced PTSD symptoms. In this brief summary, I will highlight some of the EMDR research listed in the review. The authors explained that literature identified in their search was not large enough nor sufficiently homogeneous to support a full meta-analysis. They found one subset of 3 studies comparing EMDR to an active comparison treatment that permitted a meta-analysis. This meta-analysis found greater PTSD symptom reduction in the EMDR therapy groups than in the active comparison groups. They found 5 studies that examined interventions for PTSD symptoms induced by cardiovascular illness. They highlighted a study conducted by Arabia et al. In 2011 that investigated the efficacy of EMDR compared to imaginal exposure in individuals undergoing cardiac rehabilitation, which found that at post-treatment and at the 6-month follow-up, individuals in the EMDR group had significantly lower PTSD symptoms compared to the imaginal exposure group at both follow-up assessments. They also highlighted the 2018 study by Guerrera et al. On the adapted EMDR protocol for the treatment of ongoing traumatic stress in adult women with PTSD symptoms due to cancer diagnosis and treatment. The EMDR group of 35 women received 6 EMDR therapy sessions provided in a group format over 2 consecutive days, while 30 individuals were randomized to a no-treatment control group. PTSD symptoms at post-treatment were significantly lower in the EMDR than the control group, with a large treatment effect size. EMDR also led to greater improvements in PTSD symptoms over time. At post-treatment, no dropout was reported from the EMDR-IGTP OTS group, while a 13% dropout was reported from the no-treatment control group. Another study in this review was the 2016 study from Carletto et al. That compared EMDR and relaxation therapy for PTSD related to progressive or relapsing remitting MS. Participants in both groups completed 2 initial sessions to assess trauma histories, followed by 10 60-minute individual treatment sessions of EMDR or relaxation therapy over 12 to 15 weeks. EMDR therapy sessions consisted of stabilization through visualization, followed by bilateral eye movements during recall of illness-related traumatic images. Relaxation therapy included visualization, breathing, and progressive muscle relaxation techniques. PTSD symptoms in both groups were significantly reduced at the 6-month follow-up, with no significant post-treatment differences observed between groups. However, at the 6-month follow-up, significantly more patients in the EMDR group than the relaxation group no longer met diagnostic criteria for PTSD. In other words, 100% of the EMDR subjects no longer met criteria for PTSD versus 77% in the relaxation group subjects. Based on the overall findings of this review, gold standard trauma-focused psychotherapies such as EMDR, EMDR-IGTP, OTS, written exposure therapy, and repetitive transcranial magnetic stimulation show preliminary efficacy in the treatment of medically induced PTSD symptoms. These treatments also have the advantage of being more time and cost efficient than traditional treatments. Based on their review, the authors conclude that the optimal treatments of PTSD symptoms induced by medical events remain unclear. They suggest that more comprehensive research is needed to refine and modify these promising interventions to best treat the unique manifestations of medically induced PTSD. Next, we consider the question of what constitutes successful treatment outcomes for individuals initially diagnosed with post-traumatic stress disorder. In a review of treatment results from over 1,000 individuals who completed an intensive 8-day treatment program at the Psychotrauma Expertise Center, known as PsyTrek, lead author Frederick Wessling and co-authors found evidence that individuals continued to experience PTSD symptoms after 6-month follow-up, despite no longer meeting full diagnostic criteria for PTSD. PsyTrek in the Netherlands provides an 8-day intensive trauma-focused treatment program combining psychoeducation, physical activity, prolonged exposure, and EMDR therapy. Their review of CAPS-5 total scores showed a significant reduction from pre to post-treatment and improvements at 6-month follow-up, with a small to moderate increase in symptoms between post-treatment and follow-up. They found that among those no longer meeting full PTSD criteria immediately after treatment or at the 6-month follow-up, a substantial proportion reported residual symptoms. This included over 50% at post-treatment and 45% at the 6-month follow-up. The most frequently reported residual symptoms at 6-month follow-up were negative beliefs, negative feelings, and intrusive memories. The authors comment that in clinical practice, the loss of diagnosis of PTSD is often viewed as the primary treatment endpoint. As a result, patients may be discharged prematurely or without appropriate follow-up despite the presence of ongoing symptoms or functional impairments. Their multivariate regression analysis identified several predictors of residual symptoms 6 months after treatment. The overall number of traumatic experiences was found to predict the persistence of avoidance of thoughts and feelings. Participants who reported moderate to high levels of suicidality at intake were nearly 5 times more likely to continue experiencing avoidance symptoms at follow-up, underscoring the importance of addressing suicidality as a potential barrier to full recovery. The issue of directly treating suicidal intrusions with EMDR therapy will be our focus in the 3rd episode of the podcast. In addition, the current study found those with histories of exposure to sexual violence were nearly 5 times more likely to report ongoing negative feelings post-treatment. In their discussion, they contrast the difference between loss of diagnostic status versus remission. Loss of diagnostic status refers narrowly to no longer meeting the full DSM-5 diagnostic criteria for PTSD. Remission, on the other hand, implies a broader recovery, including low residual symptom severity, restored functioning, and improved quality of life. They encourage therapists to be mindful of the persistence of specific symptoms, to use appropriate follow-up screenings, and to consider the use of additional interventions to address lingering symptoms and prevent relapse. Well, that's it for today's episode of EMDR, The Science Behind the Therapy, from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles covered in this 2nd episode of the podcast can be found at sonomapti.com/blog in the September 2025 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on EMDR therapy training programs, visit sonomapti.com, and for free articles, visit the resources section on andrewleeds.net. Thanks again for listening. We'll see you next time.